So hope you all are doing well. Today we'll do the full session on the practical guidelines of diabetes in Ramadan, which were published in 2021 via the IDF and Diabetes and Ramadan International Alliance. So basically, when we do a pre-Ramadan assessment, we should do a structured education for all the individuals, and this should include risk quantification. We should explain to the patients the role of self-monitoring of blood glucose. Risk stratification will look in detail in the next subsequent slides, and we'll try to classify the patients into low, moderate, and high risk. We should advise the patients when should they break the fast, or when to exercise, fluid and meal planning, and the most important, of course, the from the exam perspective, also the medication adjustments during fasting. So all individuals seeking to fast should attend a pre-Ramadan visit 6 to 8 weeks, ideally before Ramadan. This will help to stratify the risk and develop an individualized management plan. Now, what are the things which we will take into context when stratifying the risk and developing this individualized plan? We'll look at the detailed medical history of the patient. We'll look at the different aspects of his diabetes and his ability to self-manage his diabetes, presence of comorbidities, what was his experience in the prior Ramadan, the year before? How did he manage his diabetes? Did he experience any, or did he have a good experience while managing his diabetes, or did he have any bad experience when he manages his diabetes? The individual's ability to self-manage the diabetes, and also we have to look at other aspects which can increase the risk of fasting. For example, his nature of the work and other medical conditions. So when we stratify the risk, we are trying to classify them into low, moderate, and high risk. Let's see the risk scoring elements which will help us come to these categories. So number one, we have diabetes type and the duration. So if it is type 1 diabetes, that gives a risk score of 1, type 2, 0. Duration more than or equal to 10 years, the duration of diabetes, that gives a risk score of 1. Duration of diabetes less than 10 years, risk score 0. In regards to presence of hypoglycemia, if the patient has hypoglycemia unawareness, that gives a very high risk of 6.5, which directly places this patient into a high risk zone. Recent severe hypoglycemia, 5.5, multiple weekly hypoglycemia, 3.5, hypoglycemia less than 1 time per week, 1, and no hypoglycemia, 0. In terms of level of glycemic control, if HbA1c more than or equal to 9%, poorly controlled, that gives a risk score of 2, HbA1c of 7.5 to 9%, risk score of 1, and less than 7.5%, risk score of 0. Now, type of the treatment, if the patient is on multiple daily mixed insulin injections, the risk score of 3, basal bolus insulin or insulin pump, 2.5, once daily only mixed insulin, 2, the risk element score, basal insulin alone, 1.5, gilbenflamide, which is a sulfonylurea, 1.5. On the other hand, gliclazide or glimpramide or ripaglinide, gilbenflamide is the risk score element is 1. On the other hand, gliclazide or glimpramide or ripaglinide, the risk score of element is 0.5, which is half that of gilbenflamide. So, of course, if we were to prefer a SU, we'll go for either gliclazide MR or glimpramide or ripaglinide and not gilbenflamide during Ramadan. Now, this is the other therapy we are talking about. So, any other therapy like metformin or SGLT2 inhibitors or DPP4 inhibitors for that matter, which is not including SU or sulfonylurea or insulin. So, basically, they are talking also about the other injectable therapies like GLP-1 analogs. So, this all will be 0. Means if the patient is on this, then the risk element score will be 0. Of course, when we are calculating the total risk, we will be adding all the points. I'll give you an example in the next slide. If the patient is monitoring the blood glucose to indicated but not conducted, so for example, if he's not doing his monitoring properly, it will give a risk element score of 2. He's indeed doing it but doing it suboptimally, then that will give a risk element score of 1. And if he's doing as indicated, then it will give a risk element score of 0. If the patient has an acute complication in the last 3 months, like DK or a honk, then 3 DK honk in the last 6 months, 2 DK honk in the last 12 months, 1, and no DK or honk, then the risk element score will be. In terms of Multivessel disease, unstable multivessel disease directly jumps the score to 6.5, stable multivessel disease 2, and no multivessel disease 0. In terms of renal complications, EGFR of less than 30, 6.5, 30 to 45, 4, 45 to 62, and more than 60, 0. If the patient is pregnant and also the blood sugars are not within the targets, that directly jumps the score to 6.5. Pregnancy itself is already giving a very high risk score of 3.5. Even the blood sugars are within the target. And that is the reason why the pregnant and the breastfeeding women are advised not to fast. Not pregnant, 0. Impaired cognitive function of frail, 6.5. More than 70-year-old with no home support, 3.5. No frailty or loss in cognitive function, 0. If the patient is involved in highly intense physical labor work, then 4. Moderate intense physical labor 2, and no physical labor work 0. So you can imagine, so I'll just give you an example here. If the patient is so this is what is the risk scoring basically. If it is more than 6, directly it goes to high risk. If it is 3.5 to 6, it will go to moderate, and less than 3, 0 to 3 is low risk. Now, just giving you an example. So for example, if the patient is having a diabetes, which is type 2, okay, so that gives 0. This is newly diagnosed. So the duration of diabetes less than 10 years, again 0. But the HbA1c is 10% at diagnosis, so that gives a risk score of 2, okay. Now, this patient was started with metformin and SGLT2 inhibitor for that matter. Okay, so actually the duration of diabetes was around 2 months. Okay, and the patient was started on a combination of metformin and SGLT2 inhibitor. So again, that will be 0. So now, so far, what all points we have? We have 0 plus 0 plus 2 plus 0. So here we have risk element score of 2. Now, this patient ended up having a euglycemic diabetic ketoacidosis secondary to the SGLT2 inhibitor. And that comes as an acute complication, which is DK and HONK in the last 3 months. And 3, so this patient wanted to proceed with fasting. Now what's happened is he has so far a risk element score of 2 plus 3, which is already in the moderate risk zone. So 2 plus 3 will be 5, 3.5 to 6. So ideally this patient would be suggested not to fast. This is how we will calculate. Same for that matter, if a newly diagnosed type 2 diabetic patient diagnosed but is involved in heavy physical work for that matter, that will give directly a score of 4 and directly will place him in the moderate risk category. So that's how we'll classify the different risk stratifications. There are 2 other points which I'll mention here. One is the previous Ramadan experience. If it is an overall negative experience, that will be a score of 1. So previously, if he had fasted last year and had hypoglycemic episodes, or there was a lot of fluctuations in his blood sugar, that will be a negative experience, and that will give a score of 1. No negative or positive or only positive experience, then that will be 0. Again, depending upon the type of place which you are living in, which country you're living in, location, sometimes the hours of fasting may be more than or equal to 16 hours. That gives a risk score of 1. And if it is less than 16 hours, that gives a risk score of 0. So basically, when we are calculating and stratifying these patients, we will be adding up all the points mentioned in the question or in your clinical practice. So always in our clinic as well, we keep these charts handy so that we can add up the points when we are doing the pre-Ramadan assessment. So again, score of 0 to 3, low risk, 3.5 to 6, moderate risk, more than 6 will be high risk. So what does these categories mean? Basically, low risk means in terms of medical and religious recommendations. So medical recommendations, low risk, fasting is probably safe. Religious recommendations, fasting is obligatory in this regards. Advice not to fast is not allowed unless patient is unable to fast due to physical burden of fasting or needing to take medications or food or drink during fasting. Moderate risk. So here already the fasting safety is a concern, and these patients are suggested not to fast. Medical evaluation, medical adjustment, strict monitoring is definitely needed. Fasting is preferred, but patients may choose not to fast if they are concerned about their health after appropriate consulting with the doctor and taking into account the different medical circumstances and the patient's own previous experiences. If the patient does fast, they must strictly follow medical recommendations, including regular blood glucose monitoring. We'll look at that in the next slide. High risk patient, more than 6 points when added up, is fasting is unsafe, and even the religious recommendation is strictly against fasting. Remember, as I mentioned, pregnant and breastfeeding women have the right not to fast, regardless of not whether they have diabetes or not. So this is extremely important. And then we also looked at that risk scoring, where if they have blood glucose off target, then that is 6.5 directly, even without blood glucose without like if even if the blood glucose is in target, it is 3.5. But pregnancy and breastfeeding itself, they have a right not to fast regardless whether they have diabetes or not. Now, what are the times when we need to self monitor the blood glucose as per the guidelines? So the guidelines recommend a 7 point guide for Ramadan, where the patients are recommended to fast pre-dawn meal, which is suhoor time, then in the morning time when they wake up, then around midday, then around mid-afternoon, then pre-sunset meal iftar, 2 hours after iftar, at any time when they get any symptoms of hypoglycemia, hyperglycemia, or feeling of being under. Now, practically in clinical practice, we definitely recommend the patients to check this around suhoor time, because that is the time they wake up in the morning around 3 o'clock, 3:30, around that time. Depending upon which part of the world you are staying, it may be different. And then they definitely check it when they wake up in the morning. So that's like a post suhoor timing check. Then they should check definitely in the mid-afternoon, because that approximately the mid-afternoon time is like the fasting hour. So for example, if the fasting has started from 4 o'clock in the morning, then if you're talking about mid-afternoon around 1 o'clock or 2 o'clock in the afternoon, that's already like 8 to 10 hours of fasting, and that will give you the ideal fasting blood sugar value. And then we are checking pre-sunset meal, especially before iftar, and then 2 hours after iftar to get the post-pandal reading post a big meal of the day. So apart from the testing, all individuals should be advised to break their fast if blood glucose is less than 70. Very straightforward, milligram per deciliter, which is 3.9 millimole per liter. Always we should recheck within 1 hour if blood glucose is between 70 to 90, because there is a tendency to go low if that's happening. They should always break the fast if the blood glucose levels at any point of the time goes more than 300 milligram per deciliter, which is 16.6. They should also break the fast if they have any symptoms of hypoglycemia or any acute illness. Now let's look at the management of type 1, and then we look at the management of type 2 diabetes when fasting during Ramadan. Now, in exams for practical purposes as well as in exams, we will just be getting a scenario. So for example, we'll get a type 1 diabetic patient, and they will mention that this patient is on so much amount of basal insulin, like for example 30 units, and so much amount of short acting insulin, like for example 888 for that matter. And then they will be advising this patient is planning to fast, and they will also mention the patient's HbA1c. So we'll take into consideration the risk as well of this patient. But many a times they will not ask you about the risk. They'll ask you what should be done about their insulin doses during Ramadan. And that is all there in this chart, which we are going to discuss now. Now, if the patient is on an insulin pump, so if they have mentioned the patient is a type 1 diabetic patient and the patient is on a CSII or an insulin pump, and then they will ask you what is the adjustment you'll be doing in the basal rate of this patient. So what is the recommendation? 20 to 40% decrease for the last 3 to 4 hours of the fast. It's extremely important because that is the time when the maximum hypoglycemia sets in. 3 to 4 hours or last 3 to 4 hours of the fast. So for example, if you're in your country, the fast is ending at around 6:30 p.m. or 6 p.m. in the evening, then it will be from 2 p.m. to 6 p.m. or for example 3 p.m. to 7 p.m., whichever time in your country there is for the breaking of the fast. Now, in terms of the other thing, 10 to 30% increase for the first few hours after iftar. Why? Because that's the main meal which has the patient has taken in the evening time. This is the iftar time when they are breaking the fast. So after that, there is an immediate hyperglycemia which is happening. So we should plan to adjust the basal rate during that time. And that's why in the question it will be mentioned what times the basal rate should be adjusted. So the basal rate should be decreased 20 to 40% during the last 3 to 4 hours of the fast and increased 10 to 30% in the first few hours after iftar. Very straightforward. Okay. And method of monitoring during Ramadan when a patient is on a pump, definitely CGM will be the best method to monitor. In terms of the bolus dosing, most of these patients will have be carb counting, so it will be the same principles as prior to Ramadan. Now, what if the patient is on a basal bolus with analog insulins? Analog insulin, our aspart, glulicine, epidrad, these all things are our analog insulins. And if the patient is on a basal bolus insulin regimen, typically a type 1 diabetic patient, so what is the recommendation for the basal insulin? 30 to 40% reduction in the dose, and this dose should be taken at iftar time. So normally these patients take the basal at the bedtime. Now, whatever is their dose, for example, 30 units or 40 units at bedtime, we should be advising a 30 to 40% reduction in dose and to be taken it at iftar time. That's the recommendation in terms of a basal for the MDI regimen in a type 1 diabetic patient. What about rapid analog insulin? The dose at suhoor should be reduced by 30 to 50%. Pre-lunch dose, of course, will be skipped because there will be no lunch. The patient will be fasting during the day. The dose around iftar to be adjusted based on the 2-hour post-iftar glucose reading. So, of course, if the post-iftar glucose readings are high, or he first initially he'll take his standard dose which he takes with his dinner, which will be the same like with the iftar. But if the 2-hour post-prandial reading is high, he or she will definitely need to increase their dose pre-iftar. But the suhoor dose is reduced because the suhoor is usually lighter in majority of the cases, and that's why the dose at the suhoor meal is usually lighter in majority of the cases, and hence the dose at suhoor is, which is the morning time, is reduced by 30 to 50%. That is the advice for reduction. And as I mentioned, the method of monitoring during Ramadan, as I mentioned in the slide before, a 7-point glucose monitoring. Now, what about patients who are on a basal bolus with a conventional insulin? So here we are talking about the intermediate acting insulin like NPH insulin, or for that matter, the Actrapid, which is the regular insulin or Humulin R. Now, the usual pre-Ramadan morning dose to be taken in the evening during Ramadan. So whatever dose the patient is taking in the morning for the NPH, for example, NPH is usually taken twice a day. Now, in a scenario where the patient is taking 20 units in the morning and 18 units in the evening, so total of 38 units in the day. Now, in Ramadan, your morning dose, which you're taking prior to Ramadan, shifted to the evening time. Okay, so if 20 was in the morning, the 20 will shift to the evening time. And the 18, which was taken in the evening, so 50% of the pre-Ramadan dose to be taken at suhoor time. Okay, so for example, whatever is your dose of the morning, say for example 20 units in the morning. Okay, now 50% of that dose you will be taking at suhoor time, because of course the suhoor, after that you'll be almost fasting for a longer period of the time, almost 15 hours to 14 hours, and that's why 50% of the pre-Ramadan dose to be taken at suhoor. On the other hand, the usual pre-Ramadan dose of morning to be taken in the evening during the Ramadan. So if they're taking 20 in the morning, shift to 20 in the evening. What about the regular insulin? Dose at evening meal remains unchanged. Suhoor dose again, because suhoor meal is light, to be reduced to 50% of the free Ramadan evening dose, and the afternoon dose should be clearly skipped. So suhoor dose to be 50% of the pre-Ramadan evening dose. So whatever is the pre-Ramadan evening dose or the dinner time dose, for example, 10 minutes, 50% reduce of that, so example 5 minutes, and that will become the suhoor time dose patients who are an MDI with the conventional insulin. Again, recommendation for testing is 7-point blood glucose monitoring or at least 2 to 3 staggered readings throughout the day. What if the patient is on a pre-mixed insulin, whether it is analog or conventional? Okay, so in this, shift the usual pre-Ramadan morning dose to iftar. So for example, if the patient is on 20 units in the morning and 16 units in the evening, now whatever was the 20 units in the morning, you shift it to the evening time with iftar. And then 50% of the pre-Ramadan evening dose you take at suhoor. For example, 16 was the evening dose or the dinner time dose, 50% of that you'll take it in the suhoor. So that will become 8. So that's how we will shift the pre-mixed insulins when the patient is fasting during Ramadan. And at least 2 to 3 daily readings is recommended, or whenever the patient develops any symptoms of hypoglycemia. So that was very straightforward management of type 1 diabetes in patients who are fasting during Ramadan. Now let's look at the management of type 2 diabetic patients when fasting during Ramadan. About the medications which they commonly ask, changes to metformin dosing, once daily dosing, no dose modification required, shifted to iftar time. If the patient is twice daily dosing, no dose adjustment required, take it suhoor and iftar. If the patient is taking 3 times a day, then we can just combine his afternoon dose with dose taken at iftar, and the morning dose will remain the same in suhoor. And if the patient is taking a prolonged release metformin once a day, then no dose modification is required, just take it at iftar time. So again, many a times they will ask the question about the oral hypoglycemic agents. Metformin is one of their favorites. One of the most important drugs which they commonly ask during exams is SUs, because that's the one which really needs adjustment and understanding. So once daily dosing taken at iftar in individuals with well blood glucose level, well controlled blood, the dose may be reduced in the even in the iftar time. In the twice daily dosing, iftar dose remains the same. In individuals with well-controlled blood glucose, the suhoor dose should be reduced. So what happens is, for example, if the patient is taking a full tablet, in one tablet in the morning, one in the evening, I will definitely cut it down to half in the morning and one in the evening. Even in those patients who have once daily dosing, like for example, 60 mg for the gliclazide, or we can make it like half, which is 30 mg with iftar if the patient sugars are well controlled. Older drugs in SU class, older drugs like gilbenclamide should definitely not be used, carry a higher risk of hypoglycemia, should be avoided. Second generation SUs are preferred, gliclazide MR, glimpramide, they should be used instead. We'd already looked at the risk element score, how it is 1 for gilbenclamide and half for the other second generation SUs. So wherever possible, immediately shift the patient to an alternative SU, and then even the patients who have well controlled blood glucose, you need to consider reducing the dose. If twice daily dosing in individuals with well-controlled blood glucose, if they mentioned that in the question, HbA1c well controlled, that suhoor dose should definitely be reduced, and we generally make it half. Okay, regarding the acarbose, if we are talking, if they mentioned the question about acarbose, this in terms of modification, no dose modification is considered necessary as the risk of hypoglycemia is low. Again, if they mention in the question about pioglitazone, again, no dose modification is required during Ramadan, but dose should be taken with iftar. So I'm trying to cover all the oral hypoglycemic agents. What about short-acting insulin secretagogues like ripaglenide, nataglenide? Actually, this was one of the questions which was asked in the last SC exam about short-acting insulin secretagogues. The daily dose of short-acting insulin secretagogues based on a 3-meal dosing should definitely be reduced. Why? Because the patient will be just eating 2 times, so it will become twice a day. And it may be further reduced if the meal sizes are small. But definitely, if it is a 2-meal dosing pattern, this is suhoor and iftar, it will become twice a day. The ideal dose is thrice a day. So definitely, we need to reduce this during Ramadan. As as regards to the GLP-1, like liraglutide, lixisenatide, exenatide, have been appropriately dosed prior to Ramadan, at least 2 to 4 weeks. We should always plan it ahead. No further treatment modifications are required. Again, any GLP-1 analogs we generally prefer to start well ahead of Ramadan, and if they have been appropriately adjusted to the dose, then we can just keep the same dose prior to what was prior to Ramadan. Now, DPP-4 inhibitors do not require, again, modification during Ramadan, so no dose adjustment needed. Again, one of the exam favorites, SGLT2 inhibitors. They have a low risk of hypoglycemia. No dose adjustment is required during Ramadan. For stabilization, SGLT2 inhibitors should be initiated at least 2 weeks to 1 month prior to Ramadan. A very important statement for exams. They are recommended to be administered at the evening meal, which is iftar. Again, very important statement for exam. However, if the indication for SGLT2 initiation is cardiovascular renal protection, then the pre-Ramadan initiation should be conducted with a lower dose. Increasing fluid intake during the non-fasting hours of Ramadan is recommended. Raising awareness among physicians about recent guideline changes and benefits of new antihyperglycemic agents is important. When choosing an antihyperglycemic therapy, the impact on heart failure and renal function should be considered. SGLT2 inhibitors do not require modification during Ramadan. However, if an individual is on multiple medications, a review of the doses should be made to avoid risk of hypoglycemia. So, for example, if the patient is on insulin, patient is on SU, then we should consider appropriate dose adjustment as we discussed in the previous slides. SGLT2 inhibitor use when fasting during Ramadan should be in accordance with the usual safety and prescribing measures. What about insulin dosing in type 2 diabetic patients? And what are the changes which we should think about suggesting to the patients the short acting and the long acting during Ramadan? This we're talking about type 2 diabetic patients. So let's look at the long acting or the intermediate acting, which is the basal insulins, whether it is NPH or Detimar or Glargine 300 or Degludec, all of them once daily. If the patient is taking once daily, then just reduce the dose at 15 to 30% by 15 to 30%, whatever is the dose, and just take it at iftar instead of bedtime. On the other hand, if the patient is on NPH, Detimar or Glargine, which he has been taking twice daily because these are the insulins which can be taken twice daily, then just take the usual morning dose at iftar. So whatever is the morning dose, take it at iftar time. Suppose morning dose is 24, then that will shift to iftar time. The evening dose will become 24 and reduce the evening dose by 50% and take that at suhoor. That's the recommendation. So for example, if the evening dose was 20, that will become 10, which will be reduction by 50%, and that dose the patient will take 10 in the morning with suhoor time. So 10 in the morning, and then it will become 24 in the evening time for that matter. What about the short-acting insulins? Normal dose at iftar time, omit lunchtime dose, patient is fasting, and reduce the suhoor dose by 25 to 50%. So very straightforward in terms of the short-acting as well as the long-acting or the intermediate-acting insulins. How can we do these dose adjustments? Is a good chart which is mentioned here. Suppose patient is pre-iftar and the reading is less than 70 milligram per deciliter, then the basal insulin can be reduced by 4 units. If it is less than 90, reduced by 2 units. 90 to 126, no change required. More than 126, increase by 2 units. More than 200, increase by 4 units. On the other hand, if the patient is post-suhoor, and if the blood glucose is less than 70, reduce the short-acting insulin by 4 units. Then if it is less than 90, reduce by 2 units. If it is between 90 to 126, the post-iftar reading, no change required. If it is more than 126, increase by 2 units, and more than 200, increase by 4 units. So these are the readings with which we can adjust doses, but the important concepts which you should keep in your mind is the changes to the long-acting and the intermediate-acting doses and the short-acting doses for management of type 2 diabetic patients on in Ramadan on insulin. What about changes to the pre-mixed insulin? If the patient is just on once daily dosing, take the normal dose at iftar. Very straightforward. If the patient is twice daily dosing, take the normal dose at iftar, but reduce the suhoor time dose, which is the morning dose, by 20 to 50%. And 3 times daily dosing, omit afternoon dose. Of course, patient will be fasting. Adjust the iftar and suhoor doses and should carry out the dose titration every 3 days by the chart below. Now, in exams, again, you'll be given a type 2 diabetic patient and you'll be mentioned the patient is on long-acting insulin and short-acting insulin, what dosage changes is recommended, and you need to remember these percentages to be able to adjust the doses. Same exam scenario will be type 2 diabetic patient on premix insulin, and they will mention patient is on twice daily dosing, and they will mention what changes is recommended. So you should definitely know that you will be reducing the suhoor dose by 20 to 50% and take the normal dose at iftar. So these are all the questions which have appeared in the previous exams, which I'm mentioning now. Again, depending upon the fasting reading or pre-iftar or pre-suhoor blood glucose less than 70, we can reduce the pre-iftar dose by 4 units in terms of the premix insulin. If it is less than 90, we can reduce by 2 units. 90 to 126, no change required. More than 126, increase by 2, and more than 200, increase by 4 units. So these are the dose adjustments for the premix insulin. Now, what about the changes to insulin pump during Ramadan? This I already mentioned actually. But I will just tell you again, it is the same. We're talking about type 1 diabetic patient only. We already covered this here actually on this first part. So just remember this. This is the important thing: 20 to 40% decrease for the last 3 to 4 hours of the fast, and 10 to 30% increase for the first few hours after iftar. And the short-acting insulin or the carbohydrate counting, the patient will be doing the same. So normal carbohydrate counting and insulin sensitive principles will apply. What about the special population, diabetes with pregnancy when fasting during Ramadan? Islam provides all pregnant women with the option not to fast if they feel worried about their own health and fetal well-being. Also, fasting of patients with diabetes and pregnancy is associated with an increased risk of both hyperglycemia and hypoglycemia. So this category of diabetes patients with pregnancy or breastfeeding should ideally, it's advised not to fast. Now, what about patients with CKD and CVD when fasting during Ramadan? Diabetes is a risk factor towards cardiovascular disease and stroke. Individuals with pre-existing CVD or stroke and diabetes are at a greater risk of complications when fasting and should be cautious. Individuals with CKD stage 3 and diabetes are of high risk of fasting during Ramadan. Individuals with CKD stage 4 to 5 and diabetes are of very high risk for fasting during Ramadan. Fasting in this individual should definitely be discussed. We already looked at the EGFR charting when we looked at the risk element score, and that is how we will classify these patients into moderate to high risk. What about elderly? Diabetes-related complications such as hypoglycemia and hyperglycemia can be more frequent in elderly than younger individuals. Greater and more careful planning pre-Ramadan is needed in elderly individuals to ensure a safe fast during Ramadan. There is greater emphasis on self-monitoring of blood glucose in elderly during Ramadan fast to ensure safety. And we should definitely choose anti-diabetic agents with lower risk of hypoglycemia and definitely not SUs when we are talking about management of diabetes in elderly patients. So thank you so much. And that's the end of the full session on diabetes in Ramadan.